Dear students, good morning. Our lecture today will be about the adipose tissue derived hormones, or what is called adipokines or the adipocytokines. The objective of this lecture: first we want to define the term adipocytokines, then we will classify the adipocytokines into many categories, then we will state the metabolic effect of certain adipocytokines and how they are related to different health and disease states. Then we will define the term metabolic syndrome and what is the consequence of having the metabolic syndrome, and what is the criteria that is used to diagnose the metabolic syndrome. Adipose tissue previously was considered as an long-term energy storage organ only. It is just a storage for excess fat. Later on, especially after the global obesity pandemic, the scientists tried to find a link between obesity and the increased prevalence of certain disease like the cardiovascular disease and diabetes. So intensive investigation have found that the adipose tissue have a key role in integrating many pathways of metabolism. Adipose tissue have the ability to secrete many proteins or a glycoprotein that affect many metabolic process in the body. And because these protein or peptide or glycoprotein that are secreted from the adipocytes are secreted from the adipose cell but can affect metabolic process remotely, so they found or they considered the adipose tissue now as an endocrine organ. الاديبوس تيشو كانوا يعتبروها لفترات طويلة من الزمن انه هي مجرد storage for the excess fat، يعني اعتبروها فقط هي مصدر لخزن الدهون فقط. لكن مع ظهور انتشار obesity السمنة في كل العالم خاصة في السنوات الأخيرة، بدأوا العلماء يشوفون شنو هو اللينك بين الأوبيسيتي السمنة وازدياد نسب الإصابة بكثير من الأمراض، مثلا أمراض القلب وأمراض الديابيتس السكري وأمراض الارتفاع ضغط الدم. فشافوا بأنه الأديبوس تيشو الفات سيل لها قابلية أنه تفرز مجموعة من البروتينات اللي إلها قابلية التأثير على العمليات مختلف العمليات الأيضية في مختلف أنحاء الجسم، وبما أنه هي تنفرز من مكان محدد وتأثيرها يكون systematically، فاعتبروا أنه هذه الأديبوس تيشو هي مو فقط هي storage for fat أو energy، وإنما اعتبروها حاليا هي endocrine organ. والبروتينز اللي تنفرز من الأديبوس تيشو now is called Adipokines or the Adipocytokines. These adipokines can mediate the communication between the adipose tissue and the metabolic organ اللي هي mainly المصل liver and pancreas وكذلك ال CNS. فاللينك between them can be mediated اعتبروها في signaling molecule by the adipocytokines. If there is any dysfunction in the adipokine pathway راح انه يكون الorgan communication will be impaired، وراح نشوف انه there is a metabolic derangement in multiple tissue. From its name it is clear that adipokines or adipocytokines, if we divide the name, it means it's adipocytes, which come from the adipose tissue, and the cytokines, which come from it means a signaling molecule. Chemically, the adipocytokines either is a protein or polypeptide or glycoprotein. We can classify them into main category. Some of the polyol adipocytokines directly affect metabolism. For example, we have the leptin, resistin, adiponectin, apelin, omentin, visfatin, and other. Some of the adipocytokines have a pro-inflammatory effect and may act as acute phase reactant, while others are part of the extracellular matrix, and some of the adipocytokines have a pro-angiogenic and pro-mitogenic effect. So we can classify the adipocytokines generally into these main category. In our lecture, we are concerned mainly with the adipocytokines that affect the metabolism. This is the adipose tissue, adipocyte. This is the adipocyte, the fat cell, and it can secrete the leptin, adiponectin, resistin, retinol binding protein 4, and many cytokines. It can affect the CNS, the liver, the muscle, the pancreas, and the cardiovascular system. This effect may be mediated through either obesity-induced inflammation, obesity-induced inflammatory disease. It may increase or decrease the obesity-related inflammatory disease. It also have a role on the immune cell. The first one we will discover is the leptin. It is a peptide hormone. They have special receptors called OB gene, gene. It is OB gene. The concentration of of the leptin in the circulation is proportional to the adipose tissue mass. كل ما يكون عندنا adipose tissue, large mass of adipose tissue, the leptin level secreted by it will be also high. So it is proportional or parallel to the mass. And mainly it is a greater secretion from the subcutaneous more than the visceral adipose tissue. In addition to be found in the adipose tissue, it also can be found in the other tissue, for example in the gastric epithelium. The main effect of leptin is to regulate the overall body weight by limiting food intake and increasing the amount of the energy expenditure. Also, it has a neuroendocrine function. It has an inflammatory response. If it can affect the bone mass and the blood pressure. Mainly its effect on the CNS. It adjusts food intake and the energy expenditure. Dear students, good morning. Our lecture today will be about the adipose tissue derived hormones, or what is called adipokines or the adipocytokines. The objective of this lecture: first, we want to define the term adipocytokines. Then we will classify the adipocytokines into many categories. Then we will state the metabolic effect of certain adipocytokines and how they are related to different health and disease states. Then we will define the term metabolic syndrome and what is the consequence of having the metabolic syndrome, and what is the criteria that is used to diagnose the metabolic syndrome. Adipose tissue previously was considered as an long-term energy storage organ only. It is just a storage for excess fat. Later on, especially after the global obesity pandemic, the scientists tried to find a link between obesity and the increased prevalence of certain disease like the cardiovascular disease and diabetes. So intensive investigation have found that the adipose tissue have a key role in integrating many pathway of metabolism. It have the ability to secrete, adipose tissue have the ability to secrete many proteins or glycoprotein that affect many metabolic process in the body. And because these protein or peptide or glycoprotein that are secreted from the adipocytes are secreted from the adipose cell but can affect metabolic process remotely, so they found or they considered the adipose tissue now as an endocrine organ. الاديبوس تيشو كانوا يعتبروها لفترات طويلة من الزمن انه هي مجرد storage for the excess fat، يعني يعتبروها فقط هي مصدر لخزن الدهون فقط. لكن مع ظهور انتشار obesity السمنة في كل العالم خاصة في السنوات الأخيرة، بدأوا العلماء يشوفون شنو هو اللينك between الأوبيسيتي السمنة وازدياد نسب الإصابة بكثير من الأمراض، مثلا أمراض القلب وأمراض الديابيتس السكري وأمراض الارتفاع ضغط الدم. فشافوا بأنه الأديبوس تيشو الفات سيل لها قابلية أنه تفرز مجموعة من البروتينات اللي إلها قابلية التأثير على العمليات مختلف العمليات الأيضية في مختلف أنحاء الجسم، وبما أنه هي تنفرز من مكان محدد وتأثيرها يكون سيستماتيكلي، فاعتبروا أنه هذه الأديبوس تيشو هي مو فقط هي storage for fat أو energy، وإنما اعتبروها حاليا هي endocrine organ. والبروتينز اللي تنفرز من الأديبوس تيشو now is called Adipokines or the Adipocytokines. These Adipokines can mediate the communication between the adipose tissue and the metabolic organ اللي هي mainly المصل liver and pancreas وكذلك ال CNS. فاللينك between them can be mediated اعتبروها في signaling molecule by the adipocytokines. If there is any dysfunction in the adipokine pathway راح انه يكون الorgan communication will be impaired، وراح نشوف انه there is a metabolic derangement in multiple tissue. From its name it's clear that adipokines or adipocytokines, if we divide the name, it means it's adipocytes which come from the adipose tissue and the cytokines which come from it means a signaling molecule. Chemically, the adipocytokines either is a protein or polypeptide or glycoprotein. We can classify them into main category. Some of the polyadipocytokines directly affect metabolism. For example, we have the leptin, resistin, adiponectin, apelin, omentin, visfatin, and other. Some of the adipocytokines have a pro-inflammatory effect and may act as acute phase reactant, while others are part of the extracellular matrix, and some of the adipocytokines have a pro-angiogenic and pro-mitogenic effect. So we can classify the adipocytokines generally into these main category. In our lecture, we are concerned mainly with the adipocytokines that affect the metabolism. This is the adipose tissue. Adipocyte is the adipocyte, the fat cell, and it can secrete the leptin, adiponectin, resistin, retinol binding protein 4, and many cytokines. It can affect the CNS, the liver, the muscle, the pancreas, and the cardiovascular system. This effect may be mediated through either obesity-induced inflammatory disease. It may increase or decrease the obesity-related inflammatory disease. It also have an role on the immune cell. Hormone, one of the adipocytokines that is released from the fat cell that are located in the adipose tissue. The gene that code the production of leptin is called OB gene. The leptin sends signal to the hypothalamus in the brain and help to regulate and alter the long-term food intake and the energy expenditure. The secretion of leptin is directly proportional to the mass of the adipose tissue. كل ما يكون عندنا adipose tissue large mass كل ما يكون production of leptin is high. So the production is parallel to the adipose tissue mass, and mainly it is secreted from the subcutaneous adipose tissue more than from the visceral adipose tissue. Can be secreted from other tissue as in the gastric epithelium, but mainly from the adipose tissue. The primary function of the leptin is to regulate the body to maintain its weight. If the amount of the body fat increase, the leptin level also will increase. And if the individual lower its body fat content or percentage, then the leptin level will decrease. Sometimes this hormone is called the satiety hormone because it helps to inhibit the hunger and regulate the energy balance. So the body in this case does not trigger hunger response when it doesn't need energy. So it can serve as a gauge for energy reserve and direct the CNS to adjust food intake and energy expenditure accordingly. The receptor for this hormone is mainly in the hypothalamus. After the leptin bound to its receptor in the hypothalamus, then the body will regulate the food intake and the energy use or loss. Increased adiposity will increase the leptin production. This will inhibit food intake. Some of the problem with leptin is that when the body is functioning properly, the excess fat cell will produce leptin. This will trigger the hypothalamus to lower the appetite and allow the body to dip into the fat store to feed itself. Unfortunately, sometimes in obese, they have too much of leptin in the blood. This can cause a lack of sensitivity to the hormone. This is known as leptin resistant. Because the individual will keep eating, the fat cell produce more leptin to signal the feeling of satiety, leading to increase in the leptin production in this condition. Sometimes low level of leptin, although it is rare, but can occur, and in this condition it is called congenital leptin deficiency. If the body have no leptin in this condition, the body thinks it has no body fat, and this signal intense uncontrolled hunger and food intake. And this will be presented as childhood obesity and delayed puberty. Leptin deficiency, sometimes patient with congenital complete leptin deficiency due to homozygous leptin gene deficiency or mutation will develop extreme obesity, and this occurs very early in life. In this case, it can respond to recombinant human leptin treatment. This will reduce appetite and food intake and lead to dramatic body fat loss. These patients have a special endocrine abnormality, and all will improve by leptin replacement. واحدة من الأشياء اللي promising يعتبروها إنه ممكن recombinant leptin production can help in certain condition اللي يكون عندنا سبب الأوبستي severe obesity in early childhood. سببها إنه يكون عندنا mutation بالليبتين جين ويكون production of leptin and the level of its production قليل in the body. فشافوا بأنه ممكن إنه يستفادون these patients from the recombinant leptin treatment. Leptin is parallel to the body fat mass, but also we have other factors that may affect the level of leptin. For example, if the level of estrogen in the body is increased, for example in physiological condition as in pregnancy or by taking certain medication that are high in estrogen, for example the contraceptive pills, will increase the level of leptin. The glucocorticoid when increase, whether synthetic or natural, when we have increase in the cortisol in the blood, this will lead to increase the leptin level. Increase in the level of insulin also enhance the production of more leptin. Certain cytokines, for example the TNF, tumor necrotic factor, the interleukin 2, also increase the leptin level, while the leptin level may decrease in certain other conditions. For example, when we have increase in the level of androgens, for example testosterone, whether synthetic or natural, it will decrease the leptin level. The growth hormone also, when it's increased, the leptin level will decrease, and increase in the free fatty acid will decrease the level of leptin. The leptin is called the satiety hormone. It affects mainly the energy expenditure and the hunger, the food intake, but also it have other function in the body. For example, it affect on the CNS, have a neuroendocrine effect, and also have a metabolic effect. By its effect peripherally, it affect the homeopoiesis, have effect on immune system, and have angiogenetic factor, and it enhance the have effect also on the fetus. In addition to leptin role in controlling food intake and the energy balance, also it affects metabolism, affect the bone mass, the control of blood pressure. It have an angiogenic effect. It affects the hematopoiesis and the immune cell. It affects glucose homeostasis by affecting the level of insulin, and also regulate lipid metabolism independent of food intake, as it inhibits the lipogenesis and stimulate lipolysis in adipose tissue and liver. Also, leptin can stimulate fatty acid oxidation and stimulate fatty oxidation by activating many pathways in the skeletal muscle. It modulates bone metabolism also, both centrally and peripherally. Adiponectin is another adipocytokines. It is a protein that are synthesized mainly or exclusively by the fat cell in the adipose tissue. Many different forms of adiponectin are found. Maybe a trimer, or it may be circulate as a hexamer or a high polymer structure. Each one have a different function in the body. The concentration of adiponectin depend on the amount of body fat, but the correlation or the relation between them is inverse. When we have a high fat mass, there will be decrease in the level of adiponectin, and vice versa. The lower the body fat, the more the adiponectin. It acts by bounding to its specific receptor called adiponectin receptor. We have two types mainly, the adiponectin R1 adipo and adiponectin are 2. When we have decrease in the amount of fat, we have increase in the level of adiponectin. This means that in obesity-linked disease, for example, heart disease, insulin resistance, type 2 diabetes, and atherosclerosis, these are the diseases that are well known to be related to obesity. So, in this disease, the level of adiponectin will be low. It has a major role in the metabolism of both carb and lipid, and also it has important anti-inflammatory effect and anti-atherogenic effect. It has increased the sensitivity of tissue to insulin, so it has an insulin sensitizing effect. It decreases the level of glucose by suppress the gluconeogenesis. We know that the gluconeogenesis is the production of glucose from non-carb source. And this effect, the production of excess glucose, is inhibited by adiponectin, and this helps the body glucose to be maintained within the normal level. Also, it stimulates glucose uptake in the skeletal muscle, so that this will decrease the level of glucose in the circulation and maintain it within the normal range. Stimulate the oxidation of the fatty acid and help to increase the transport of glucose, of fatty acid and free fatty acid and glucose to the muscle, liver, and adipose tissue. By doing this, it will help to maintain the blood glucose within the normal range and prevent the glucose intolerance. Also, it has an anti-atherogenic effect. It has an anti-inflammatory effect and decrease the vascular injury. All these effects are maintain the body in a healthy state, so that and we know that the increase in the body fat will decrease in adiponectin. So this is the link, one of the mediator that connect the adiposity to the disease state. Whenever the body have a normal weight, the level of adiponectin will be high, so it will maintain all it have by influencing the carbohydrate and lipid metabolism and maintain all these the level of these for example carb and lipid within normal range, so this will lead to a healthy state. Otherwise, when we have obesity, the body fat will increase, the adiponectin level will decrease, so all the effect that we talk about by suppressing the hepatic gluconeogenesis, stimulate the glucose uptake in the skeletal muscle, the fatty oxidation stimulate, all this will be decreased, so that the blood glucose will increase, insulin resistance will increase, and this will lead to diabetes and other atherogenic and cardiovascular disease. Accordingly, in certain disease, the low level, we will find that the adiponectin level is low. For example, in essential hypertension, in diabetes mellitus, and in coronary artery disease. And since adiponectin is a major modulator of insulin action, and it will decrease in type 2, and by contributing to the peripheral insulin resistance, so it have a significant insulin sensitizing as well as anti-inflammatory property. Giving therapeutic adiponectin is promising both for control of certain obesity-related disease, for example, DM and other disease, but it is still experimental. Maybe in the future this will be very beneficial. Resistin is another hormone that is produced by the adipose tissue. It is a polypeptide in nature, and it is rich in cysteine. Also can be formed by the immune system. This hormone suggested to link obesity to type 2 diabetes by modulating the steps in insulin signaling pathway and lead to the insulin resistant. Resistin will decrease insulin sensitivity. Its name Resistin comes because of it reduces insulin sensitivity and enhance the development of resistance to the action of insulin. The concentration of resistin increase when there is increase in the mass of a fat cell, like leptin. Increasing the mass of fat cell will increase the production of resistin. It mediates many effects and it stimulated by many factors. For example, inflammatory process will enhance the production of resistin. Certain cytokine, for example the interleukin 6, will also enhance its production. Hyperglycemia, gonadal hormone, estrogen, progesterone, growth hormone, all will enhance the production of resistin. The resistin represent a candidate for the etiology of insulin resistance and type 2 diabetes. Another subject that is related to obesity and its related disorder is called the metabolic syndrome. The metabolic syndrome has received attention in the past years because of globalization of obesity. It consists of multiple interrelated risk factors of metabolic origin. So certain metabolic disturbance that is associated with medical disorder. This metabolic derangement is directly promote the development of atherosclerotic cardiovascular disease and diabetes. The metabolic risk factors that are included in the metabolic syndrome include the atherogenic dyslipidemia, which include the elevated triglyceride, apolipoprotein B, when we have increase in the small LDL particle and the decreased level of the good or protective cholesterol, which is the HDL cholesterol. Also, one of the criteria for the metabolic syndrome is the elevated blood pressure, elevated plasma glucose, a prothrombotic state, and a pro-inflammatory state. So, accumulation of all these or part of these lead or can be diagnosed in any person as having the metabolic syndrome. The core or the hallmark of the disease is insulin resistant. So, the central obesity and insulin resistant are the causative factor of all these metabolic derangement that eventually lead to what is called metabolic syndrome and its consequences, which are increase in the risk of cardiovascular disease and diabetes mellitus. Many associated factors with the metabolic syndrome, for example, impaired fibrinolysis, microalbuminemia, and other disorder. So, the central is the metabolic syndrome. We have one arm is the insulin resistant, the visceral obesity, which are the very important causative factor. We have associated with it the low HDL cholesterol, high triglyceride, and hypertension. Many organizations have set certain criteria to diagnose the metabolic syndrome. One of them we will talk about today is the National Cholesterol Education Program Adult Treatment Panel 3 اللي هو مختصرها هو NCEP ATP3 criteria. They put certain criteria to diagnose metabolic syndrome. The most important is these 5 criteria. In any person who have 3 criteria of these five, it is considered or diagnosed as having metabolic syndrome, and he have a risk factor for the development of many diseases, including the atherosclerosis, the diabetes, polycystic ovary, hyperuricemia. So these five criteria are: if the waist circumference for a male is more than 102 cm, and in the female more than 88 cm, it means that he have a central obesity, and it is one of the criteria for diagnosis of metabolic syndrome. So having a central obesity diagnosed as having a waist more than 102 cm in male and 88 cm in female is one of the diagnostic criteria. The other criteria is having an elevated serum triglyceride more than 150 milligram per deciliter, or sometimes when you measure the level of serum triglyceride, it is within normal, but the patient is on treatment by anti-hyperlipidemic medication. So whether he have high triglyceride or on medication that lower the triglyceride, in this condition it is considered as another criteria. The other one is low HDL cholesterol. The level of the high density lipoprotein, when it is low, it is one of the diagnostic criteria for the metabolic syndrome, and the cutoff value for this criteria is when the level of the HDL is less than 40 mg per deciliter in male, or less than 50 mg per deciliter in female, or if we in the history of the patient we found that he is taking treatment for hyperlipidemia, so we consider it as a risk factor. The fourth criteria, when you have hypertension, whether both the systolic and diastolic are elevated, or only the systolic or only the diastolic are elevated, it is one of the diagnostic criteria. So if the systolic is more than 130 millimole, one more millimeter mercury, or the diastolic is more than 85 millimeter mercury, or if in the history we found that he is taking medication for hypertension, this is also a diagnostic criteria. And if he have fasting blood glucose more than 100 milligram per deciliter, or he is already on medication, anti-hyperglycemic medication, so in this case it is considered also as a diagnostic criteria. Any patient who have three out of these five criteria is diagnosed of having the metabolic syndrome. It is associated or starts from obesity. It is lead to oxidative stress, insulin resistant, increase in the uric acid, increase in leptin, decrease in adiponectin, increase in oxidized LDL, increase in the inflammatory marker as the tumor necrotic factor, increase in certain cytokines like interleukin 6 and decrease in interleukin 10. Eventually all of these will lead to insulin resistant dyslipidemia, hypertension, and metabolic syndrome. Usually metabolic syndrome is associated with other abnormality. In addition to the insulin resistant and hyperglycemia, we have atherogenic dyslipidemia, endothelial dysfunction, prothrombotic, pro-inflammatory condition, and excess production of ovarian testosterone, in addition to polycystic ovary disease and hyperuricemia. Thank you. Another subject that is related to obesity and its related disorder is called the metabolic syndrome. The metabolic syndrome has received attention in the past years because of globalization of obesity. It consists of multiple interrelated risk factors of metabolic origin. So certain metabolic disturbance that is associated with medical disorder. This metabolic derangement is directly promote the development of atherosclerotic cardiovascular disease and diabetes. The metabolic risk factors that are included in the metabolic syndrome include the atherogenic dyslipidemia, which include the elevated triglyceride, apolipoprotein B, when we have increase in the small LDL particle, and the decreased level of the good or protective cholesterol, which is the HDL cholesterol. Also, one of the criteria for the metabolic syndrome is the elevated blood pressure, elevated plasma glucose, a prothrombotic state, and a pro-inflammatory state. So, accumulation of all these or part of these lead or can be diagnosed in any person as having the metabolic syndrome. The core or the hallmark of the disease is insulin resistant. So, the central obesity and insulin resistant are the causative factor of all these metabolic dearrangement that eventually lead to what is called metabolic syndrome and its consequences, which are increase in the risk of cardiovascular disease and diabetes. The metabolic syndrome, metabolic dearrangement in it, are associated with primary disturbance in the adipose tissue. Abnormal visceral fat accumulation, which is known as central obesity, that result maybe from the physical inactivity and excess calorie, will and increase in the adipocyte, act as an endocrine organ and increase the inflammatory cytokine. Generally, this syndrome may be defined as increase in the waist circumference, decrease in the serum high density lipoprotein, increase in the serum triglyceride level, increase in the blood pressure, and insulin resistant. It may be associated with other abnormality like abnormal fibrinolysis and hyperuricemia, in addition to maybe polycystic ovary disease and other. The center is in the metabolic syndrome. We have insulin resistant, visceral obesity, low HDL cholesterol, high triglyceride level, and hypertension, in addition to increase in the risk for many diseases. To diagnose the metabolic syndrome, many organizations worldwide have put certain criteria, and one of the they differ in certain requirement to diagnose the metabolic syndrome. For example, the NCEP ATP3 criteria, which is the National Cholesterol Education Program, Adult Treatment Panel 3 is one of these organizations. Other one is the WHO and the American Diabetic Association. All have certain criteria. They have some similarity in the criteria. We will discuss one of them, which are the criteria set by the National Cholesterol Education Program for diagnosis of metabolic syndrome. It assigned 5 criteria. Any person who have 3 out of these 5 can be diagnosed as having metabolic syndrome. The first criteria is waist circumference. Waist circumference, when a person have a central obesity and a waist circumference is more than 102 cm in male and more than 88 cm in female, this is the first criteria to diagnose metabolic syndrome, which is the central obesity. The second one is when the level of triglyceride in the blood is more than 150 milligram per deciliter, or by history he is on any medication that decrease the blood lipid level, so he take anti-hyperlipidemic medication. The other criteria, the third one, when the high density lipoprotein concentration is less than 40 milligram per deciliter in male or less than 50 milligram per deciliter in a female. We know that the high density lipoprotein have a protective role, so if its level is low, it is considered as one of the diagnostic criteria for metabolic syndrome. Maybe the level at time of diagnosis may be normal, but in the history he is taking anti-hyperlipidemic medication. In this condition, we consider it as a risk factor or one of the criteria to diagnose metabolic syndrome. The other criteria, when he have any patient who have blood pressure and systolic blood pressure maybe 130, more than 130 millimeter mercury, or the diastolic more than 85 millimeter mercury, or maybe even one of them, not both systolic or diastolic, even only the systolic or only the diastolic, or in the history he is taking a medication for hypertension. This is enough to diagnose as a criteria to diagnose metabolic syndrome. And the last criteria is when he have blood glucose level is more than 100 milligram per deciliter, or he is taking any medication to treat the hyperglycemia and diabetes. So these 5 criteria, any person who have 3 out of these 5 criteria is diagnosed as having metabolic syndrome. He is risk for diabetic, atherosclerotic disease, diabetes, hypertensive, polycystic ovary, hyperuricemia, and its complication. These are player for the metabolic syndrome: obesity, oxidative stress, a change in the metabolism of the adipocyte and the production of the adipocyte, increase in certain cytokines like interleukin 6, decrease in the interleukin 10, increase in certain adipocytokines like leptin, decrease in the adiponectin, increase in the resistin. All these lead to insulin resistance, dyslipidemia, hypertension, and the hallmark is the metabolic syndrome. And thank you.